This is a relay project.
Real Talk starts right now. Here's Ryan Jesperson.
You know, there's not a subject that Canadians care more about than healthcare. It's true. It's personal. It's something that affects pretty much everybody across the country. We don't spend more on anything else other than healthcare. And if the system is strained, let alone collapses, well, you've got a real problem on your hands. You're literally talking life and death. So this episode of Real Talk is for those of you that are staying home from work today because you've got a little one, or maybe it's you with the sniffles or a full-blown respiratory infection. This is for those of you that are hopped up on painkillers because you've been quoted 18 months till your hip replacement. This is for those of you that spent 18 hours in an ER and left out of frustration, or whatever else. There are millions of stories across Canada and thousands of professionals that are working around the clock to keep this healthcare system afloat. There's the politics of healthcare. There's funding issues, and we're going to get into all of it, or at least most of it, with two physicians, one in Western Canada, one in Eastern Canada. They've joined forces to launch a new podcast, The Doc Talk. Episode 1 drops today. In just a moment, you'll meet them both. This episode of Real Talk is happening with the support of Business Career College, and they've got a focused message for the senior financial planners and finance professionals out there. Anybody paying attention to what Bitcoin's doing over the weekend? Oh my gosh, talk about a rally. You know, whether or not you're down with Bitcoin, whether or not you're sold on NFTs, chances are you're going to have clients that expect expert advice and an informed perspective on those sort of things. They're going to have questions about the blockchain and Bitcoin and other cryptocurrencies. You want to know what you're talking about. Whether you're giving them the thumbs up or the thumbs down, you got to be able to justify your position. And that's why Business Career College has just launched a brand new designation. It's the CDAA. That's the Certified Digital Asset Advisor. This is your way to stay knowledgeable about cryptocurrency and the future of decentralized finance. The promo code Ryan20, all one word, is going to knock 20% off the investment you make in furthering your own career when you sign up for the CDAA designation today at businesscareercollege.com. Well, what a pleasure it is to welcome two physicians, two moms, and two podcasters to the show on this morning. The first back from the Remembrance Day break, Dr. Shazma Mithani, well known to this audience. She's an ER physician in Alberta's capital city of Edmonton at the Royal Alex and the Stollery Children's Hospital, as well as an associate clinical professor at the U of A Med School. It's nice to see you back. Yeah, and I love that you've brought a friend with you as well. Dr. Sheila Wijayasinghe is joining us. Dr. Sheila, to her patients, a family doc in the Big Smoke in Toronto, practicing at St. Michael's Hospital, the medical director of primary care outreach at Women's College Hospital. And of course, a lot of folks will recognize Dr. Sheila. She's been the resident health expert on The Social on CTV for more than 10 years and a previous columnist with the Globe and Mail. Dr. Sheila, you, I believe, are making your Real Talk debut. I don't think you and I have ever spoken before, so welcome to the show.
Thank you so much for having me. It's so great to be here.
Yeah, congratulations on the new podcast. This has got to be exciting for both of you. I know you've been wanting to do something like this for a while, Shaz.
Yeah, no, it's exciting for both of us. Sheila and I have been talking about this probably for like a year, Sheila, I think, right? That we've been talking about this. It was interesting because like every time you come here, you introduce me, but now when you added podcaster to the end of it,
Well, check out your font on YouTube now. You can see it's co-host The Doc Talk.
Ooh,
this is a whole new thing for you.
Yeah, it's like a new thing to add. So yeah, no, we've been thinking about it for a long time. Kind of like what you said at the beginning here, Ryan. The healthcare space is a scary space to navigate. It's certainly becoming a more challenging space to navigate. And Sheila and I have already both been doing work both separately and together in our social media spaces and beyond to help educate the public. And we wanted to come together to do that in a more cohesive way together. Yeah, in
2024, Sheila, doctors or physicians are communicating with patients and the public in drastically different ways than I guess even 5 years ago.
100%. I think we're really taking the lead from the public right now in a lot of these topics because we're catching up in many spaces in medicine, and people are finding their knowledge online. And so they're bringing information to us. They're trying to find solutions for their healthcare needs. As Shad says, we have a healthcare crisis, as you mentioned early on. And these are the ways that we can do better for our patients, is raising awareness and spreading the word around how to get good care when maybe you have struggles to access care, which many of us do.
So I have, I won't reveal any, personal information, but somebody close to me admitted to a hospital in Edmonton over the past couple of weeks, and I went to visit them when they were in the ER. I guess, would you say they were being triaged? Is that they were sort of in limbo, like, and I guess you can hear about what's happening in the healthcare system, and we talk a lot about it, but until you witness it firsthand, you don't really get it. So I walk into the ER. It's got to be Edmonton's busiest hospital, right? For those that don't know, the Royal Alex it's like the inner city hospital. It's right downtown in the city core, so it serves a very diverse group of people. Yeah. But I walk into that ER and wow, like this is where you work every single day. Yep. But I'll let real talkers know, how many chairs would you say in that waiting room? Like 80 to 100? Yeah. Approximately? Yeah. Every single one of them full. The odd one may be empty with a backpack on it because somebody's like coughing and wearing a mask and someone else is trying to keep some distance. But what really struck me, and it probably won't be a surprise to folks to hear this, but stretchers, or you call them gurneys or whatever you call them, the roller beds, like head to toe, all the way down Shazma, every single hallway that I traveled as I'm going to find my loved one, and I'm going all these different hallways, and I'm realizing there's got to be another 30 people at least in the hallways. And a shout out to the professionals that are there, from the nurses and the security guards checking people in. You've got paramedics there, obviously. You've got nurses and you've got physicians trying to see people. And I'm just like, I left there sort of a little bit rattled, to be honest with you. And I bet even though the two of you are doing this and you're in that ER every single day, it probably still never gets totally normal.
No, because it's actually like, it's when people are in the hallway, it's like such an undignified way. Yes. To have to provide care to people, or for them to be waiting in those spaces. I mean, like you said, we're bursting at the seams in acute care. We have been for some time. A lot of it, Sheila can speak to, has to do with just the lack of access in the community as well, which is a big reason why we started this podcast too, right? But, when people are sicker, they come to the Emerge, they need acute care and hospital care. And right now, the demand outweighs the supply, essentially. And that's why we have people lining up in hallways in stretchers. That's why we have inpatient units that are over capacity. Everybody in the system is trying to do everything that they can to help treat patients. That's what we want to be able to do at the end of the day. We always want to just treat our patients with whatever resources we can find.
Yeah, I didn't see a bunch of like nurses and doctors like hanging out, drinking champagne in the side room, catching up on their favorite Netflix episode. Everybody was kind of running off their ass. But I guess I came to a pretty clear understanding very quickly of why, if you came in there with like a badly sprained ankle, you'd probably be waiting hours and hours and hours to see somebody, because, next thing you know, you get an ambulance in there with a gunshot wound.
Well, exactly.
Somebody's, got to be seen right away.
Yeah.
Sheila, Dr. Sheila, is it the exact same thing in Toronto where you're at? I mean, this isn't just an Alberta story, obviously.
No, I think it's across the country that we're seeing this. I actually trained in Alberta. I'm from Edmonton as well. So I know the Alex very well. I trained there for many years. So I came out here for residency, but the same issues happening here as well. So I work at one of the larger hospitals, very similar to the Alex at St. Mike's, and we have long waits. It's overflowing. It's like spilling out the door sometimes when people are waiting, especially when we come to things like cold and flu season. It's such a busy time. And certainly, as you mentioned, Ryan, people are staying with an ankle injury, which hopefully that would be managed by primary care, like myself, a family doc, but people don't have family doctors right now. In Canada, in 2019, 4.5 million Canadians didn't have access to a family doctor or a nurse practitioner who also provide primary care. That number has grown to 6.5 million people across the country who do not have access to this kind of care. And so we can't blame them when they're looking for support, when they're injured, for things that should be managed in family medicine, but they have to go to the emergency room as a result. But then that adds to the weight, that adds to the load that's in those spaces, and it just creates more of an issue, unfortunately, that we're lacking in primary care in Canada.
I'm not surprised to hear 6.5 million, like approximately 1 in 6, maybe 1 in 7 Canadians. But let's also point out that some of us, myself not included, but if you're lucky enough to have had a family doc for a while, you have a rude awakening in store. if that doc hangs them up or retires, and then you re-enter the pool trying to find one. And I just know that's the case based on Johnny and I talked about that even in our own personal experience trying to find family doctors over the past couple of years. The question that I think most people really care about when you're talking about strains on the healthcare system, we'll get into some specifics, and I want to talk about surgeries. We'll talk about, it's respiratory infection season or respiratory illness season.
And that's what our first episode is all about.
Yeah. By the way, I should let people know you can find the Doc Talk anywhere you get your podcast, Spotify, Apple, and of course you can find them on YouTube as well. Just search the Doc Talk. Nice logo, by the way. The stethoscope turned microphone.
My husband did that.
Your husband did that. Wow.
Yes.
Talented. Is he a professional designer or just good at what? Yeah.
He is. Yeah.
Lucky to have that in-house. But people want to talk solutions. And let's say if we put the two of you in charge, and maybe you can't sum it up in 10 seconds, but if you wanted to start addressing wait times in ERs, and we can evolve this to talk on surgeries and the like, a lot of people are going to talk about funding. And then, there's members of the public as well that see the numbers on what the feds transfer to the provinces and what the provinces allocate to healthcare. And they go, really? We can't just keep throwing more money at it, can we?
I think so. The solution to the acute care crisis is bolstering primary care. I've said this you've heard me say this. I'm like a broken record. Primary care is the foundation of healthcare. And the return on investment in primary care, like if we want to talk about this at an economic standpoint, the return on investment is massive. Ideally, if every single Canadian had access to primary care, whether it be through, in some way, shape, or form as part of a team, a family doctor, a nurse practitioner, some sort of primary care team, the idea is, and the evidence shows this, is that if their diabetes is controlled, if their COPD is controlled, if all of their chronic healthcare conditions are controlled, they're not needing access to acute care and emergency medicine. And that's expensive care. Hospital care is expensive care, which is exactly why investing in primary care has huge returns in investment. And so, yes, there needs to be some investment there, but it is for a long-term savings.
Dr. Sheila, how do you think you might approach it if you're sitting down with Ontario's health minister, you're sitting down with Premier Ford? What are you going to tell them?
There's so much I'd like to say to Premier Ford. There's so much in terms of exactly what Shaz said around the funding piece needs to be there, but we need to train more family docs. We need to put more funding into this. There is a commitment that's been made. The federal government did increase funding towards the different provinces because that is where the decisions are made around where the funding is allocated. And so different provinces have allocated increased funding towards training more family docs. And so that's a big piece where we can increase the numbers that way, increase capacity, because as you mentioned, there are a lot of folks retiring right now as well. And so that's one piece. We need more medical schools. PEI is opening a medical school. We opened the Northern Ontario Medical School recently, and that is specifically catering towards increasing primary care. It's not to put out more specialist care. It's actually for primary care specifically. Then we need to look at other models of care. We have a lot of international medical graduates who are looking for work, and there may be more innovative solutions around how do we incorporate them into care and supporting this space. And family doctors aren't the only ones that provide primary care. Nurse practitioners are a great resource that we can also lean on to increase capacity as well.
What do you see from students that are entering or that are making their way through med school at the U of A? You hear all kinds of things about how it can be difficult to get in, or there's limited spaces. You hear a lot about, and this is anecdotal, but it seems to make sense to me that with all the noise around the strains on the healthcare system, there may be some students that might be bright and shining lights coming up that are deciding to pursue careers elsewhere. What are you actually seeing?
Yeah, Sheila and I were actually just talking about this last night. So yes, there is, like she mentioned, we need to be able to have more funding to train more medical students and residents. But so a family doctor resident that graduates is not necessarily, a comprehensive family medicine doctor. Not, the doctor that's seeing you and I, like Sheila, who is seeing patients and caring for them over their lifetime. Many family medicine residents see how crappy family medicine is right now and don't want to practice comprehensive family medicine. So they're either doing some extra training to do things like sports medicine, anesthesia, emerge, other sorts of kind of offshoots of family medicine that is not that cradle to grave medicine. And so that is a big problem that we're seeing as well, is that people who are still finishing family medicine residencies aren't actually becoming comprehensive family doctors because they see their mentors who are struggling. I see that in Alberta, I talk to my colleagues in family medicine. We have these conversations all the time about how trainees that are coming through don't want to have the same life their mentors have because it's hard when you have a shortage of healthcare workers, everyone else has to pick up the slack more, and it's not a great space to be in.
Mm-hmm. And you look at the dollars and cents of it as well, and I think family docs, the model's broken there. When you break it down to what they're on the hook for. I think most audience members know I'm the son of a family doctor.
Yeah.
I saw it firsthand, but I just know that you've got to be an entrepreneur as well. You've got to have a good business sense around you, and you're running a practice. And I don't know. I mean, you refer to cradle to grave medicine, and I love that. Like back in the day, that was kind of it. I mean, really back in the day, your family doc might have done the delivery, right?
Absolutely.
And I mean, all the way through, like maybe delivering the eulogy at the funeral kind of idea.
Yeah.
But I don't know that that's super old school. That's probably not how most people are going to experience medicine anymore,
it's just more rare now, right? We're not seeing family doctors practice that way because of all of the issues that you've identified. I mean, it's like running a small business. Sheila can certainly speak to this more, but it's like running a small business. There's overhead. If that funding isn't adequate, there's no incentive to practice medicine in that way right now.
Doctor, you are like, you have a family practice right now that you operate.
I do, yeah.
Can you take us into some of the challenge? I mean, as soon as I ask you, for the benefit of the podcast listeners, you get a big smile on your face. So obviously you feel called to it. Obviously,
I love what I do.
You love what you do, and we're lucky to have people that do. But take us into some of the challenges that the average civilian might not be able to process or understand.
For sure. So when I work with my colleagues, I think, and when I teach the residents, I work at a teaching practice. And so we have residents and medical students, and we do a lot of mentorship around encouraging folks to do the comprehensive medicine that Shaz was describing around the cradle to grave. Where I have patients in my practice that I delivered because I used to do low risk obstetrics. They're now 18 years old. Like, it's actually quite interesting for me to be able to see them grow. And that's such a fulfilling part of my practice, is that I get to support people through all of their life stages. And that's a privilege for me to do that, but it's very difficult to do that as well. And it's harder because of the costs, as were mentioned. So there's overhead costs. There's overhead costs for some practices that are 30 to 40% of what people take home. And each visit that you have, and especially in family medicine, a large part of our practice is also supporting people's mental health. That's a large part of what we do. So I have 15 minutes with a patient booked. I often stretch it out to 30 minutes. For that visit, I'm maybe billing $35. And then if you think about my colleagues who are being billed 40% of that $30 for that visit, it doesn't add up to very much at the end. And we're not employed by, and so we have to save up for our taxes. We don't have a retirement plan. So that's where there's like a real stress on my colleagues and myself who are experiencing this. And that's why they sometimes will do a different type of practice and focus their care to sports medicine or cosmetic medicine or something along those lines. So I believe that my colleagues want to do a really good job with their patients. They believe in our healthcare system to be a place that should be safe and caring for everybody, but there's so many strains on the system that really make it difficult for us to do that job and to stay in comprehensive medicine as a result. I try to encourage my residents to do this work. I think they see the beauty of seeing our elderly patients and seeing I have multi-generations in my practice, right? I have the grandparents, I have the kids, I have their grandchildren, and it's so important for me as a family doctor to see people within the context of their family. But that we're losing that quite a bit in family medicine. And I think that's sad because that's actually what draws a lot of us to this work.
For reference here, this is reporting from Hannah Alberga with the Canadian Press. Canadian Institute for Health Information, this is just within this last week, is projecting healthcare spending in Canada will reach a new high this year. The annual report released 5 days ago says total health spending expected to hit $372 billion in Canada. That's about $9,054 per Canadian. Americans are going, that's it. But the national analysis predicts the expenditures are going to rise by about 6% this year compared to 4.5% last year, 2% 2 years ago. The healthcare spending expected to represent about 12.4% of Canada's gross domestic product. That would be, minus the pandemic years, the highest ratio in Canada's history. And experts are saying with an aging population, though I always think that's a weird thing to say because we're always aging. We've always been aging. Everybody's always aging, but we get it.
But people are living longer.
The boomers, people are living longer. There are more strains on the system. They're saying that when health expenditures are outpacing economic growth, we could wind up in real trouble. So you're going to have politicians, and this isn't, I'm not saying using that as a pejorative. I mean, their job is to manage budgets. Their job is to make tough decisions. They're going to have to make tough decisions on efficiencies, and I think people that are waiting for surgeries or people that can't find a family doctor or in a million other scenarios are going to get really concerned when they start to think of what might be cut or what might be on the chopping block next.
I go back. I think we're looking at this the wrong way. Like all of that, a lot of that investment is in Band-Aid solutions because we haven't thought about this in a long-term way, right? So right now, because the system has crumbled, acute care is strained, primary care is strained. All of the investment now, because there was no foresight really in this, is in trying to create solutions in an already failing system. Whereas if we look at this a different way and look at it as, if we invest in primary care again, like that investment is going to go a lot further than trying to just throw money in an uncoordinated, non-innovative way. And so I think really politicians, the people that make decisions, need to take a step back and look at what the evidence shows and look at where that money is going to get the most bang for buck, so to speak, because right now a lot of that money is going into acute care where really, it should be going into both, but if we really focus on primary care, that's what's going to have the biggest bang for our buck in terms of investment. It's just those Band-Aid solutions aren't going to work. And it's tough because everything is on, an election cycle. And so it's challenging to entice politicians to look at things in more of a long-term way.
Yeah. And I don't blame or I don't fault politicians for when you get into a role. Let's use Alberta as an example. So Danielle Smith comes in, she goes, well, I'm going to basically blow up the entire system. Not the word she used, and then they're creating all these different pillars and the boards are getting shuffled and all this kind of stuff. And I guess that's obviously got to be part of it. We always use sports metaphors, but if somebody comes into a perennially losing franchise, nobody's safe. They're going to have to, everybody's jobs are on the line. But for the average person, the average citizen, that's not the type of thing that's going to help them tomorrow.
No, and if I'm being honest, I don't think that's I agree. I don't think that's the type of thing that we really need to be focusing on right now. Like the bureaucracy and governance piece of it is really actually not valuable. That's not what's going to get Albertans and Canadians what they need. We need to be looking at this as in terms of how are we going to increase human resources and how are we going to increase access to primary care and take the load off acute care? And that's not by reorganizing an entire system.
We're talking to Doctors Shazma, Mithani, and Sheila Wijayasinghe, co-hosts of the Doc Talk podcast, just launching today. Dr. Sheila joining us from Toronto, Dr. Shazma joining us live in our Edmonton studio. Sheila, you've said, I know a big part of your work is to educate people to know their rights in the healthcare system and to be able to advocate for themselves and their loved ones. This obviously may be more of a case-by-case basis when I ask you what you're telling them. But are there a couple of things that you think every Canadian would benefit from knowing to be able to better advocate for themselves or somebody that they really care about?
Sure, absolutely. I think, what I start with is you have the right to ask questions. You have the right to come in and with those concerns that you have and not be dismissed. I think that happens very often, again, when we talk about the strains on the healthcare system. It affects how people are being cared for because the healthcare provider may be burnt out. But you do have the right to come in, ask those questions. I always suggest to patients to come in prepared, maybe write down what's going on so that because you have a very limited time with your healthcare provider, like a family doc or an emerge doc too, you want to know what you're coming in with, what your symptoms are, how long they've been affecting you, and how they're affecting you and the impact that they're having. So come in prepared. I always also suggest, if it's possible, not everybody has this available, but come in with somebody or bring a notebook with you. That could be your accompaniment. But if you come in with somebody else who can be a second set of ears, it can be really overwhelming, especially in an emergency setting, but even in a family practice setting, to talk about what's going on. It's a vulnerable space. So if you have somebody else who's there as a support person to be a second set of ears, that also really helps. And they can also remember things afterwards. We only remember a very small amount of what we're told in healthcare settings, unfortunately. And so sometimes when my patients leave or when patients leave a setting, they actually call me after they've gone to a specialist, for example, and say, hey, Dr. Sheila, I didn't understand what happened at that appointment. Can you walk me through it? And so we go through it together, and that's my role as a family doctor to help navigate. But again, having that second person alongside you can be super helpful. It is very difficult to navigate the healthcare system. I know that personally as a patient. I went through fertility treatment for years. I didn't realize how difficult it was to be a patient until I became a patient myself. And that was a big impetus for me and for Shazma, I know, in terms of why we want to do this and spread the word. Because again, so many folks don't have access to care. And if we can be a place of support to give information, perhaps that'll help that conversation go a little bit easier when you do get to see a healthcare provider.
Yeah, I couldn't agree more. And that's absolutely a big reason why Sheila and I started the Doc Talk, is because myself, as someone who's gone through the system, my kids have gone through the system, so many close friends and family have gone through the system. And without that inherent knowledge of how the system works, which Sheila and I have as an advantage being in the system, it is really challenging to figure out where to go, what to do, who to see. And the idea with the Doc Talk is that we are really just breaking it down, keeping it simple, getting rid of all the jargon and all the excess stuff to help people understand health at, an easy to understand level, but also help them understand how to navigate the Canadian healthcare system, because it is continuing to be more and more challenging to do that.
How about this from Acute Awareness in our YouTube live chat? Says, I got a family doctor in Toronto in less than 2 weeks, and they gave me a few options. Says, I'm not sure if the system is broken in certain areas. I'm thrilled to hear that for you. Cactus Sheriff says, we managed to find a family doctor right after our kids were born, right before all of this madness started, and we are grateful as hell. What about this one from Steve Fetter? Says, for the first time in my lifetime, he says, I've just seen information released that shows that the U.S. has easier access to healthcare than in Canada. He says, our system is broken. We should be able to invest in our own health, period. I want to ask both of you about that, because Shazma's face just went, okay, here we go. But that could mean a bunch of different things.
Yes.
And so we'll talk about that, whether we want to call it alternative delivery, whether we want to call it privatized healthcare, whatever it is. We'll get into it with the co-hosts of the Doc Talk, a brand new podcast that's just launched today. We're thrilled to be talking to both of them right here on Real Talk. Plus, by the way, Canada detecting its very first presumptive case of the H5 bird flu in British Columbia, a teenager. I'm going to ask these two how big of a deal that is. We kind of get freaked out, members of the public, when we hear stuff like that, but let's go to the doctors. Let's ask the experts. That's coming up in just a moment. If you're tuning into this episode because you're interested in a career in healthcare, I want to direct you to athabascau.ca. That's Canada's open university with hundreds of different programs and courses, including for healthcare professionals. You can browse the programs and courses on their website, learn a little bit more about how AU works, including the applications and admissions process. They've got student supports, including financial supports. And of course, the best part about AU is the barrier of that brick and mortar post-secondary is removed. Your only commute is to your device, and you are determining your own schedule. You need to take time off to help out at home, or maybe take a mental health break, or heck, maybe you just want to go surf in Costa Rica for a month. You can do it if you're a student at athabascau.ca, because you're selecting your own path. AU, Canada's open university. We are thrilled here on Real Talk to be partnering with UCAN Youth Services, and I want to direct you to their website, ucan.ca. Over the next number of months, you're going to learn a little bit more about how relentless they are in helping young people that are at risk right now. We're talking 18 to 25-year-olds find pathways toward economic independence. They're doing incredible work with young people, working with employers, maybe just like you, to create entry-level opportunities and workplace training that allows these folks to get their careers started on the right foot, including the Road to Work program. Check that out. Super cool. Successful candidates earn a $15 an hour wage to start. It gives them the tools they need to enter the construction, road building, and traffic safety industries. And of course, that's just one step forward on what everybody hopes will be a nice long journey. Again, that's UCAN Youth Services at ucan.ca. And we mentioned California Closets, how proud we are to work with them, and that's because we hear happy ending after happy ending. Folks that have gone to California Closets with that assignment, a custom closet or a storage solution for the entire home. Now, a lot of you are going, I don't know if I can afford a California Closets. I've seen the work that they've done on Real Talk, and that stuff looks expensive. Let me tell you, they can work with any budget. They've got a team of designers and a team of installers that have seen it all. They've accomplished it all. And they've got all kinds of ideas that you may not have even thought of. You can request that free consultation. Check out the work that they've done, including in garages, by the way. They're absolute masters of that. Custom spaces for your space and your budget at californiaclosets.ca. Hanging out with the co-hosts of the Doc Talk podcast. That's Dr. Sheila Wijayasinghe and Dr. Shazma Mithani, British Columbia, recording Canada's first presumptive human H5 bird flu case. A young person suspected may have been picked up in a children's hospital. Dr. Bonnie Henry there, Chief Medical Officer of Health, says we're on it. She didn't say, this is my understanding, my paraphrase, but it's not a huge deal. Nobody needs to hit the panic button yet. But what do we need to know about this?
Yeah, I mean, we don't need to hit the panic button yet. I think certainly everybody is primed, myself included, having just gone through a pandemic, right? And so I understand the anxiety. I think it's important to understand that, these types of viruses are going to continue to evolve and move between different hosts, or so different species. And one of the things to kind of keep in mind is just sticking to the basics, right? That all of these viruses, these respiratory viruses, are transmitted in similar ways between humans. And so through respiratory droplets, airborne, and contact. And so keeping it to the basics, stay home when you're sick, put a mask on if you're sick, and to protect yourself as well, wash your hands. All of these things, increase ventilation, all of these things are important in general from a respiratory virus standpoint. But just to have that overlying knowledge that the more people get infected with any virus, the higher chance it has to mutate and then become more aggressive, exactly what we saw with COVID. And so I think it's important that that attention is being brought to this, just to help increase awareness for the general public that we continue to need to be careful with these sorts of things.
So yeah, the experts in BC say they're conducting a thorough investigation to fully understand the source of exposure, but they say that this young person could have got this from a bird or from another animal. Dr. Sheila, the average person is going to go, do I need to be keeping my kids inside? Could the family pet pass this along? Are there steps that someone should take, or is this kind of a fluke?
I mean, this is the first case that we've had. They think that this is likely related to a poultry farm or some form of connection to that. And so, you don't have to keep your kids inside. Kids should be outside. It's actually healthy to be outside. It helps that being outside is better than being inside often, right? Because we have more airflow. So no, we don't have to panic right now. We have a very strong surveillance system in Canada that helps to monitor these things. It's good that this was picked up, because then we can act on it and continue to monitor it. And as Shaz said, now we know. So we need to continue to be aware and vigilant, but no panic button yet.
Could you get it from chicken, like in a grocery store? If the source is a poultry farm, is this? Good
question. No, it's with live poultry that the transmission is thought to occur.
Okay. What about generally speaking, respiratory? It's you don't call it respiratory virus season, do you? But it is.
Yes. Yeah, that's exactly what we call it, respiratory virus season, right? There's in the northern hemisphere, that season is kind of in the fall winter months for us. And then in the southern hemisphere, it's the opposite, because those are the fall winter months for them, which is our spring and summer.
So are you seeing it? Are you seeing an uptick in cases right now?
Absolutely. Yep. So we had a surge of COVID kind of at the, late summer into the early fall. Still seeing some COVID cases
this year.
Now.
You're talking
this year. Yep.
Yeah. Still a thing.
Still, absolutely, still a thing. And then now is the time where we're going to start seeing, that influenza start to spike up. Typically, as we go through November into December, and then January, February are the highest months, kind of historically speaking, for influenza. So we are right in and then dozens of other viruses that we don't test for and don't have vaccines for yet are also circulating around this time. And, you mentioned, should I keep my kids inside? And Sheila answered, well, no, it's actually better to be outside. One of the reasons that we see a surge in respiratory viruses in the fall and winter months is because people are staying inside more, and that transmission is occurring more readily. So yeah, absolutely. We are in that season. We're seeing it.
Is it what's it like when you're in the ER and so you're saying COVID is a thing again? You're seeing an uptick in cases. I mean, obviously, I hearken back. I remember back to before a vaccine was developed, and it was medical professionals like the two of you, and basically in hazmat suits and wearing respirators or not respirators, but you know what I mean, the big masks, and just really wild stuff. It looked like sort of out of an apocalyptic type film. And for a lot of people, that was maybe their experience. Now, when you're seeing an uptick again in COVID, and you're getting people walk into the ER, and they could, quite frankly, have COVID, and many of them probably do. Is it any different than any other day? Or, is everybody masking up more than they normally would? Or how does it change day to day in 2024 now that it's, we're not sort of officially in the pandemic, it's endemic now, et cetera, et cetera. What's it like firsthand?
I think in general, since the pandemic, there is just an increase in uptake of appropriate infection measures in hospitals, right? And so anytime I'm going in to see a patient that has a potential infectious disease, I put a gown on, I put gloves on, I always have eye protection on, I always have a mask on.
You always do?
Always.
Every single day?
Every single day. Yeah. And part of that is because we don't know what we're walking into. And the other part is also, it's actually quite inconvenient to be sick, right? There's so many people who have respiratory viruses around us. I also work in a pediatric emerge. There are lots of sick kids. We talk about in the podcast about how kids are germ buckets. So there's lots of transmission of viruses. I don't like being sick.
Well, you don't
and I don't want my
to
kids to be sick.
Family,
exactly.
Right?
Exactly. And so that protects me. and it protects the people around me too.
Yeah, Dr. Sheila, we saw some interesting numbers. Canadians, I mean, geez, sometimes people say talk shows can perpetuate negative trends, but I also don't believe that we should ignore them. But we did see that the Canadians' vaccine enthusiasm had kind of dropped off a little bit. People got their first two with COVID, and then some got the boosters, and then some folks now are back to not even getting the flu shot anymore. And are you seeing that in your practice? What are you noticing? What are you telling people?
Yeah, that's a great question. I do think that is a real trend that we have seen. I think people are vaccine. There's a bit of vaccine fatigue that's been happening, and understandably so, because we did suggest a lot of vaccines over the last several years. But there's a reason behind that. Vaccines are one of the best options that we have for protection. And how we make the vaccine for the flu virus, for example, is really looking at those trends of what have been happening in the Southern Hemisphere beforehand. And so in the last several months, what did they see? And then that helps us predict what we're going to be seeing coming up in Canada in the coming months. And so as a result, it's a combination of viruses that are seen in Thailand, in China, in Australia, that were actually ahead of us in this trend, in the flu spread, and the vaccine has been created as a result. So yes, we are seeing people be a little bit less into getting their vaccines, but with good education and understanding that this is how we can best protect ourselves and our loved ones, especially our most vulnerable in our population. So if you have anybody in your life who's over 65, or you have kids in your life who are under 5, they're at the most, or folks who are pregnant as well, especially in the second half of their pregnancy, they're at higher risk of flu-related complications. And vaccines are one of the best ways that we can protect not just ourselves, really it's for those folks in our communities that we need to protect the most. And so we do see that fatigue, but I always suggest to my patients, we have a big campaign happening right now in our own clinic. We're emailing patients, and actually people are coming in. They understand that there's some good evidence behind this, and this is why we're suggesting it.
Did you saw this story last week? I'm sure you did, Dr. Shazma. The Alberta government has decided no more publicly funded vaccines for most community medical clinics. The province is going to limit publicly funded vaccines to a couple of dozen different community clinics. This a permanent cutoff, says the government, of the flow of these publicly funded vaccines to these clinics. Obviously, a wave, I think, of concern from healthcare providers, to say the least. Shipments of these vaccines that the public is covering the cost on. And again, we can circle back on where it makes sense to spend the money and the cost of not spending. But these medical clinics saw those shipments stop back in April when that distribution contract expired. A replacement was never hired, which meant that a lot of family docs didn't receive COVID-19 or flu vaccines for their fall campaigns, the immunization campaigns. Other clinics have reported that they've been unable to access a number of other publicly funded vaccines for months, including the shot that protects against pertussis, whooping cough. You like how I talk like I know what I'm talking about? I don't. I hope I pronounced that okay. After months of uncertainty, I'm referencing CBC News reporting here, punctuated by messaging, the disruption was temporary. The Alberta government has told CBC News it's ending the distribution program, which was launched 3 years ago in an effort to increase access. This is your home province. Your thoughts?
It's extremely disappointing. It really is. I mean, it's not just family doctor's office, it's pediatricians' offices as well. And when we know that vaccines save lives, and when it comes to something as simple as the flu shot to prevent influenza and the complications from influenza, it is that access piece is so important. And so adding an extra step of, okay, well, I have to go to an immunization clinic if it's a child under 5, or that I have to go to a pharmacy. Whereas if you're already seeing your primary care provider, whether it's your family doctor or pediatrician, and they can just offer you that shot there and then, it's just going to increase the uptake in vaccinations. And that's like that. Those barriers are not because of vaccine hesitancy. Those barriers were like, I can't find time in my schedule to add something else to do. Mm-hmm. Taking that away is just honestly extremely disappointing. I mean, you talk about where to invest, primary care and public health when it comes to like vaccinations are part of a public health campaign, right? Where we're trying to keep the general population healthy and not sick. That's where investment matters. And something like having access to vaccines and not increasing barriers but taking them away has a high return on investment as well.
Dr. Sheila, what is walking pneumonia? I keep seeing walking pneumonia.
I mean, I think this is something that Shaz sees quite a bit. I see it in my office as well. So it's when folks come in and they have a cough, they may have a fever. Generally, I mean, in our practices, I don't get to see the same level of acuity as Shaz sees, but they're generally okay, but they're feeling short of breath. They may have a fever, they're feeling fatigued, and we take a listen to their lungs and they sound pretty gunky and yucky. And so they may have actually like a pneumonia as a result. So pneumonia is basically an infection of the lower respiratory tract. We have the upper respiratory tract, of our nasal passages, our sinuses, and then down into our lungs, we can get, if it gets inflamed and infected, you get a pneumonia. And so folks are walking around in the community with this kind of pneumonia pattern. It can be viral in nature from one of these viruses that we've mentioned. And influenza is one of those viruses. COVID can be one of those viruses. RSV is another virus that we're seeing an uptick of now as well. And then, but it can also be bacterial. So if you're noticing that people, if you're having difficulty breathing, shortness of breath, folks who usually can be like, I can do the stairs normally. I have a cough and I have this happening, plus a fever, body aches, any of those things, get checked out because that could be a pneumonia that we need to treat.
Okay, so by the time by the time somebody comes to the ER, I guess people are wired differently. Some folks are in the ER. I hate to say part of the problem, but we'll call it real talk. Somebody's got the sniffles and they're in the ER and clogging it up. We want them to go see their family doc or call HealthLink, right? But then you've also got that the other group. Maybe they're old schoolers and they're proud of, they're going to tough it out, right? They're going to
usually
work
the
through
farmers.
it. The farmers, you know.
Oh my gosh, I miss Alberta farmers.
Oh, they're the best.
They're the best.
You know, they're the best. But they're going to like tough it out. They're going to play hurt. But when you talk about the viral nature of that, I mean, it could obviously be a real problem.
Yeah, and so like the term walking pneumonia, so Sheila did a really good job of kind of giving an overview of like different types of pneumonia. But this term that we're seeing in the media, walking pneumonia, it's actually a specific type of bacteria called mycoplasma. And the reason that it's called walking pneumonia is because, you know, kind of as Sheila mentioned, those classic symptoms that we see with like a severe bacterial pneumonia where someone is feeling really crummy, short of breath, can't walk upstairs, has a fever, can't get out of bed, the symptoms that would typically prompt someone to come to the emerge, they're often lacking with this mycoplasma pneumonia. So people feel like those symptoms are slower in onset and slower in progression. People can still typically continue their day to day, and so often don't seek help, even because they're actually feeling pretty okay. And then it's not until they go see someone like Sheila, their family doctor, or come into the ER and see me, where something just doesn't feel quite right. You know, either there's an abnormality when we're listening, they've had a fever for a prolonged period of time, or those symptoms are just lasting. It prompts us to do an X-ray, and then oftentimes we're surprised to see pneumonia on the chest X-ray, and it does actually require different antibiotics to treat it compared to the usual antibiotics that we use for pneumonia. And we are starting to see, definitely in the US, a big uptick in these mycoplasma pneumonias, or so-called walking pneumonias. And we're starting to see an uptick in Eastern Canada, and I think that's likely going to spread our way as well into Western Canada.
I appreciate you putting that on our radar. I want to get back to what Feder was talking about here in the live chat, talking about essentially, like people investing in their own healthcare, people spending on their own healthcare. And he says Americans have better access to care. He says the numbers I reference aren't accurate. I don't know what he's talking about. Says it's not as much as I think. I guess that depends on who you talk to. We had friends that were just down in the States trying to receive cancer care, and it's obviously the cost is mind-boggling, in the hundreds of thousands of dollars. But there's a lot of talk about the future of healthcare in Canada and different steps that people will take. I know that there was public outcry around a clinic that was launching in Calgary, kind of like a private health clinic. It's certainly not the only one. I know people, you probably know people, audience members probably know people that pay a membership fee, that have a sort of a private healthcare clinic that they can attend. There's a family doctor there. They can get their MRIs there. There's all kinds. They can tap in. They can talk to nutritionists. The cost is depending on your perspective. It's either a lot or not a lot for these folks. I think for people it's between, I've heard between $2,000 and $6,000 a year for these types of memberships. And then there's surgeries. Obviously, a lot of people. A friend of mine who's an orthopedic surgeon tells me they're not doing any elective surgeries right now. That's not their call. That goes beyond them. So you got surgeons that are ready to go that are not operating on things like knee and hip replacements that aren't emergencies, right? So my understanding of elective is like if you shatter your ankle snowboarding, you're going to get a surgery. Yep. But if you need a knee replacement, you're not getting the surgery right now. And you could be waiting for a year and a half or longer, right? So some folks, if they have the resources, are going elsewhere. They're going to Ontario, or they're going to the States, or they're going to Mexico for these surgeries, and that works for them. Not everybody loves that, obviously. We've talked about it on the show before. If you ever want to light a fire under Canadians, start talking about alternative healthcare delivery. We know that, but it is part of a lot of people's reality. I'm curious to pick both of your brains on where you think the future of that is. I imagine that you'll have an opinion on resources being pulled out of the public system and how that's a problem. But when it comes to questions like Stephen has here in the live chat about people spending on their own healthcare, how do you wrap your mind around it as a physician?
I can't blame people for wanting to find ways to access the system. Like I can't, like, I get that, right? People want to be able to have access to care. The problem as a provider and someone who understands the system very well that I see is kind of what you alluded to. In a current climate where we have a scarcity of human resources, so we don't have enough nurses, doctors, respiratory therapists, all of these things, when you start to have a parallel system or an alternate delivery model, it pulls resources from the people who can't afford it in the public system. In an ideal situation, sure, if we had an abundance of healthcare workers everywhere, sure. You know, there are well thought out models in a lot of European countries. We often get compared to European countries. But it's like comparing apples and oranges because they have had this done in a very thoughtful way. They have an abundance of healthcare worker resources, but they also have a much bigger investment in public healthcare. So they have pharmacare, they have dental care, they have all of these physiotherapy, they have all of these things already covered by the public system. So the private system actually doesn't do very much because the public system is so well resourced. And so when we talk about bringing alternative funding models into the Canadian healthcare system, it can't just be done as like this Band-Aid solution, because then what happens is in a situation where we already have scarce human resources, it does pull away from the public system and it then is to the detriment of the public system. And so, you know, I hear that there needs to be innovation and I agree that there has to be innovation, but it certainly needs to be done in a thoughtful way because we are at huge risk. I mean, look at the NHS, for example. They're a perfect example of what, if it's not done thoughtfully, the public system suffers. And we are certainly at risk of that in Canada because we already have all of these human healthcare resource shortages that is going to cause that pull away. We've seen it happen in other countries, and I think we need to listen to that.
Dr. Sheila, are you seeing patients in your own practice go stateside or go to private clinics? I mean, you know, spend their own money. Some folks are cashing in their RSPs to make it happen.
Yeah, you know, I work in an inner city hospital, and so not so much. I do have some folks in my practice who do seek their corporate health plan at work covers their cost to see a private clinic where they pay that membership fee, like you mentioned, Ryan. So they get access to like a full physical every year. And the challenge with that is that, you know, that as Shazma was saying, they're doing a bunch of things that aren't actually necessarily needed for this patient population. They're getting a stress test when they don't have chest pain. They're getting an MRI when they don't actually have pain. And so it's an interesting use of resources that is actually a waste of resources. And so it's interesting to see that parallel system as well, where you do get, it feels really great for patients to have that increased access. And I understand, as Shazma said, like people are looking for support, so we cannot blame them for paying out of pocket to do that if that's within their capacity. But you also have to look at the quality of care that's being offered in these spaces. And it's not always evidence-based or helpful in the long run. And it actually ends up costing the system more in the long run as well. So I do see that. I also see the models of virtual care coming up that are really interesting. You know, the pandemic taught us that we can do some virtual care. Patients really like that because they don't have to take a day off work. They don't have to find parking, which is a nightmare. When I come to Edmonton, I have my dentist in Edmonton actually, because I can actually go park at the dentist clinic, whereas in Toronto it's very difficult.
Wow.
Like parking, childcare, all of these costs are a lot, right? And so for patients, we can actually do virtual care. And there are these virtual care models that have come up to offer that support. I know many of the virtual care directors and the owners of those companies, and it's interesting to talk to them because they say, you know, if we lived in a perfect system where public healthcare system was covering the needs of everybody, and again, covering the needs where everybody had a family doctor, we wouldn't exist. And that would be an ideal world. But they do exist because they're a convenience factor. And in that situation, I mean, I understand that it doesn't replace the need for an in-person care provider for many people, but it offers like a bridge for some folks. And I see the value in that as well, but we have to, it's a very fine balance where we don't want to slip into the NHS, which is a UK model, where they've really seen this fragmentation of care between the private and the public system.
Yeah, I know somebody that he went and got like the full body scan. I think it was like $2,000, but and for some people that's just obviously not an option. For this guy, he was just like, I just want to know, and like, who could blame him? Like, if you have the means, or that's where you prioritize that, if you're going to do that instead of if he doesn't have kids, you don't have a family vacation or whatever, who wouldn't want to know?
Yeah, and I think I get that, and I think part of the problem is that there are providers who offer that when they know that it's actually not evidence-based.
Sure, they're doing it for right. They're justifying the membership fee. Yep. They're justifying the rate. Yep. And then real talk, the two of you probably deep down inside might not blame a colleague who chooses, I don't hesitate to use the word easier, but I mean, remove some of the challenges and the barriers around being a practitioner in one of these clinics.
Absolutely.
They don't have to do the admin. They don't have to worry about this, that, the other.
Yep, absolutely. And I think, kind of stepping back to those full body scans, just so that the listeners know, the evidence shows that these don't actually find anything earlier. And
Is
actually,
that right?
Yes. And it leads to unnecessary investigations that could then potentially cause harm, right? Like you could have a cyst in your liver that could be there forever, and you wouldn't even know about it, and you die from some other cause. But let's say a full body scan picks this up, and then you get an intervention, you end up having a complication and a bleed into your liver that wouldn't have happened if you hadn't had this full body scan that was like where the cyst was asymptomatic and you were going to die from something else already, right? And so that's what I mean when I say that these scans are not evidence-based. Like, yes, it might make you feel better, but the practitioners that are offering these understand the evidence and know that, when I talk to my friends who are radiologists, they cringe at these things because they know that it's going to find things that mean nothing. It's going to push interventions, increase spending, unnecessary spending like Sheila alluded to, and lead to an increase in complications.
I've never heard that perspective.
Yeah.
So now I get to tell him he wasted $2,000.
Exactly.
It's so interesting. I have an actual example of this where we call them incidentalomas. So they are basically findings that are incidental findings that actually don't have an impact on your health outcomes and your longevity or anything. So they're incidental findings, but when we see something, we have to then act on it, right? We can't just leave it. So it ends up being, I had a patient who had gone to one of these clinics, had some breast imaging done for no reason. She was really young, and we know that young individuals with younger breasts have denser breasts. And as a result, she ended up having repeat imaging done. It caused a lot of health-related anxiety, understandably. She needed to then go for a biopsy. It was negative, but then she had a complication from that biopsy. She bled into the space and had an infection, and it became a very big issue, whereas she probably never would have actually had that exam done, as Shazma was saying. And so again, we understand why people want to have more information. Like we talk about, bridging that knowledge gap, but some of these things don't have good evidence behind them to actually warrant doing those tests.
That's a great point. I appreciate you taking that on. I want to jump into our live chat. You won't be surprised here. There's a ton of comments here, and people are coming at it from all different ways. That's kind of healthcare, how it works. Alberta Girl says, I'm at high risk for colon cancer. My screening routine is every 5 years, but the system is so backlogged, I'm on a list, and it's now been 7 years since my last screen. She says our system is broken. You can understand how that would be of concern to somebody that's maybe lost family members to that or understands their own reality. I also saw it's kind of an underhanded compliment, but I hope you both can take it in the right spirit. So Kenzie in our live chat says these two doctors are both wonderful. Kenzie, I'm paraphrasing. I don't see your comment anymore, but she basically said something like, it's just too bad that they believe that big pharma will fix everything. And then there's been some commentary and some responses to Kenzie's comment in the chat, and some folks are just saying that's because there has been some institutional trust lost. And it's not just medicine. It's happened in law. It's happened in education. It's happened in media for sure. Maybe in closing here, I'd be curious to know, and maybe your new podcast is part of your answer to that. But how do you respond to that, to the institutional trust, that respect that's kind of lost? So, I don't think anyone will ever forget banging pots and pans for healthcare workers, and then that evolved into some people spitting on healthcare workers a year later.
One side note, our episode 3 is going to be on colorectal cancer, so tune in for that one.
Oh, good. That's for Alberta Girl.
Yeah. I think this is a big part of the reason why Sheila and I felt it was important to be in this space, and why I continue to encourage credible, regulated health professionals to be in this space, because over time there has been this dissolution of trust. When you look at the data, doctors are still actually the most trusted individuals when we do public polling, but in this age of social media as the primary source of information, there is this pervasive narrative that doctors are in the pocket of Big Pharma. I want to assure everybody that I get zero money for prescribing anything. And an enormous majority of physicians want to avoid medication and avoid pharmaceuticals. We would prefer that you stay healthy, that you have primary prevention, and that you don't have to come in and get all these expensive treatments, because it's not better for you and it's not better for the system. But I do understand that growing mistrust, and I think part of the solution to that is continuing to have voices like Sheila's and mine in this space to help people understand the nuances of how the system works, how it works when I prescribe a medication to somebody, like I said, the overarching desire to not use medications. Like, these are all things that we need to start having public conversations about to help increase that trust again in the general public, because I hear you. I hear that it's been lost, and it's actually important for the public to question us and question what we're doing. And we want to be part of that conversation so that we can help people understand how things actually work.
Yeah, question everything. That's not a bad thing. Dr. Sheila, last word to you.
Yeah, same thing. I think in us doing this public facing work, we know that people are going to be asking us questions. And Shaz and I see this as an opportunity to rebuild some of that trust that has been lost. I often am apologizing on behalf of the healthcare system because I know how difficult it can be. And we want to be able to rebuild some of that, help people know what their rights are. The stories that we hear all the time are heartbreaking. Like, it is not an easy system to navigate. And as Shaz said, like, my goal when I see patients isn't to prescribe a medication and send them through the door. I actually always talk about lifestyle as a first line treatment for folks. And so that's really what we need to do, is talk about that. That's what we want to share on our podcast. We want to rebuild that trust and support all of you through your journeys, because it is really difficult. And we're trying to work and advocate at the level of education, but also we're advocating at the government level. Shaz and I both work to advocate for increased access to care and support. And so those are the things that we want to do. And we need the public's help in doing that. Like, your ideas are great. We hear you. And that's what we're here to do, is to support you through this time.
By the way, did you know that at canadasmostrespected.com, you can actually see polling on the most respected professions in Canada? And the most recent polling they have up is for 2022. Paramedics, right at the top of the list, they issue a respect score. So paramedics have a respect score of 92.0. Firefighters right behind them at 91.4. Nurses, farmers, and medical doctors are the top five, followed by pharmacists, members of our armed forces, scientists, airline pilots, grocery store owners. That's kind of an interesting one.
Interesting.
Transit workers. I thought, you couldn't pay me enough to drive a public bus. I wouldn't do it for $300,000 a year, not a chance. Teachers are up there, and then it goes down and down, and I had to keep scrolling to find journalists. 58.4 is there. Lawyers a little bit lower than that. TV and radio talk show hosts barely pass at 54.0. Bankers are below us, though, which I don't know. That's kind of interesting. Members of the clergy, no doubt hit by probably the Catholic Church scandals, I would imagine. Professional sports players, 50.6, which is weird.
Interesting.
You sometimes feel like they could get away with anything. We love them unconditionally as long as they perform. Right at the bottom of the list, elected members of parliament at 46, which is amazing. Advertising practitioners, if you work in advertising, 41.6. Car salespeople, and then at the very bottom, owners of social media platforms at the very bottom.
I am so happy to see so many regulated professionals and scientists on the top half of that list.
Right?
Yeah, I think that is such an important thing for the public to see, and also for people in those professions to see.
Yeah, it's been so good hanging out with both of you. Congratulations. This is a really exciting day. I remember when Real Talk launched on day one, you're so jacked because you've been working hard and you had a big idea, and you guys are putting it out there. And obviously, I know we're going to build a big audience and do a great public service. Dr. Sheila Wijayasinghe and Dr. Shazma Mithani, the co-hosts of the Doc Talk podcast. You can find them on Instagram at the Doc Talk Pod. You can also find them on Apple Podcasts, Spotify, and of course on YouTube as well. Do them a solid, subscribe to those platforms, and make sure you rate their show. That'll help them in the algorithm and make sure that this gets in front of as many people as possible. Thanks for hanging out with us. It's good to see you both.
Thanks so much for having us.
Thank
today,
you.
Ryan.
Thanks very much. This conversation has been made possible by the team at Complete Care Restoration, and you can find them online, obviously 24/7. They're also ready to respond in person on that same schedule. You check out the website, you can see what they've been doing for more than 25 years, restoring properties and rebuilding peace of mind. Professional property restoration services based out of Edmonton, but doing work all across the province, including communities that have been greatly impacted by wildfire. That's not all they do, though. Flooding, black mold, asbestos removal, you name it, they've seen it, and they've got the certified professionals to handle that job. They deal directly with your insurance company, so you can take that off your plate. How much of a relief would that be? If disaster strikes, we've worked with Complete Care Restoration. We recommend them with 2 thumbs up. Again, you can learn more about them or get in touch at completecarerestoration.ca. And there's a big birthday celebration happening. Our friends at Friesen Brothers, they're going to be happy about those numbers. Grocery store owners, one of the most respected professions in Canada. There you go. Well, Charlie, which is Friesen Brothers' sourdough starter, is turning 9 on November 17th. I know Johnny's excited about that. If you know sourdough, you know nobody does sourdough better than Friesen Brothers. Charlie is a natural culture crafted from simple ingredients, flour and water. And Friesen Brothers sourdough bakers feed Charlie every single day with 100% Alberta flour, ensuring his enduring presence and enhancing the unique quality of the bakery products. Charlie is so special. He's actually in the World Sourdough Library in Belgium, which is the only facility in the world dedicated to housing sourdough cultures. We just all learned something today for sure. And Friesen Brothers literally ships 100% Alberta flour to feed Charlie all the way over in Belgium. How cool is that? They're keeping it real. You can learn more about Charlie at friesen.com/Charlie. And on November 17th, to celebrate Charlie's birthday, Friesen Brothers is going to gift a free cinnamon bun or a cinnamon spread when you purchase a full sourdough loaf. That's coming up on November 17th at your local Friesen Brothers.
Happy birthday, Charlie.
Happy birthday, Charlie.
Let's all sing happy birthday to Charlie.
You and I had some fun. We've done some pre-records that are going to air.
Oh, I can't wait
They're
to hear
going to play in Friesen Brothers stores. As people are going to be singing happy birthday to Charlie. It's a lot of fun.
I'm going to be going by I'll just be hanging out there for like 2 hours just to catch it.
Oh, yeah, man.
Because I want to see how they gather everyone together.
They're doing it. They're doing it on the hour.
Blowing out the candles.
On the hour.
That's amazing.
Yeah. If you haven't tried that Friesen Brothers cinnamon spread, that is some next level stuff.
Yeah.
It's good to be back with you. It's good to be back with this audience.
Fiery chat today.
Yeah, it was. Well, I mean, we start
Always
talking
is
about
when you start
medicine,
talking about medicine,
you know, and I understand the points. It was Steve Fetter in our live chat that was talking about people want to spend or invest in their own healthcare. I 100% understand where the doctors are coming from and talking about kind of the dark side of that or maybe the unintended consequences of that. And then you've got everybody. I mean, it was Alberta Girl there talking about colorectal or cancer screening being bumped from the 5 year to the 7 years. I feel like these days everybody knows somebody that's having to wait way too long for something that could be deadly serious.
Yeah. And then it's weird. Like I saw someone else say, "Hey, I've had one every 6 months." Regardless, but maybe that's just because you've got a good physician and a good hookup and you've had it forever. But we talked about how if you've got to get a new doctor, it's crazy. But one thing about how people were saying, doctors push big pharma. When I had a physician, I'm looking for one now. Hey, hit me up at tech at RyanJesperson.com. I'm looking. I would always go in and say I'm stressed, or my back hurts this week, or I have anxiety. I would. Not always, but I would inquire, like, hey, is there a magic pill or something I can take?
Yeah, Ozempic.
My doctor would always go to, you're stressed, you need to exercise more. You should eat better, drink more water, get more sleep. He would always do a laundry list of things before he would even start talking about medication or prescriptions or anything like that. So this idea that, like, anytime you go into an office, especially now, I know, wait times are long, and then when you get in there, you get 20, 30 minutes max, if that, and they're pushing you out. But, this idea that they're just giving you a pill and going away, that's not true. Secondly, I want to say one thing. people are always saying, like, people in the chat, why don't they tell you to eat better? Why don't they tell you to exercise? They do tell you that, but at the same time, they're not nutritionists. It's like if you go to a massage therapist and say, give me some fitness tips or teach me yoga. That's not what they're doing. They're concerned with treating a problem, right? They're not there to tell you, they're not the ones who are supposed to like train you how to exercise that you don't get there. Their job is simply to address the problem that you've come in and done, right? So
and most
they didn't go to school to be nutritionists.
Well, and you want professionals kind of staying in their lane in the sense of
course,
like you don't go to an estate lawyer if you have a criminal defense issue, right? Nor do you go to a criminal defense lawyer to handle something else, right? It sounds like Darren's getting good care in our chat. He says my doctor is always lifestyle first.
Yeah.
When I have complaints, as I've been prescribed things as a last resort or when necessary. Darren says, but I've been very happy with my care, which is good. Meantime, Horse Lake Ranch, unfortunately, girlfriend is suffering an addiction. The good news is that is an addiction to sourdough bread. And so he says,
happy birthday, Charlie.
He says, I'm going to be letting her know about Friesen Brothers on November 17th. Good call, Horse Lake Ranch.
Ben says getting more sleep can be hard to do. Tell me about it, Ben. I mean, I think that's the one thing everyone needs more of, and there would be so much less disease and reason to go to a doctor if we got more exercise and more sleep, but it's hard to find time.
And we run ourselves sort of like to the grind. We burn the candle at both ends. You and I talked about this off camera and and I encourage each other to try to be better on things, but then I'll be guilty too. This is the worst. I already know all the stuff. And I even say this to a physician when I talk to them or anybody else, where you go, I already know what you're going to tell me, right? I already know you're going to say.
Drink more water, sleep.
Drink more water, sleep more. Don't take your phone to bed.
Stop looking at your screen.
Last night I was so proud of myself for going to bed early, and then I scrolled stupid content on Instagram for like 45 minutes.
It's the worst. You get drawn in.
You get drawn in, and there you go. So these lifestyle changes, a lot of you were saying you'd like to hear the host of the Doc Talk again on the show. I think that we could make that a regular thing, but make sure you check out their podcast. I wanted to get to a bunch of emails. We got some good ones, obviously, on the U.S. presidential election. I'm not sure if you heard, but that went down last week. Donald Trump will be the next president of the United States, and we've got some emails on that, plus incredible conversations. Our most recent Real Talk Roundtable, lest we forget, on the importance of Remembrance Day, and then an exclusive with a 99-year-old D-Day veteran by the name of Marty Jones. You want to tee that up? Marty joined us in studio. This episode, we released it on Monday, November 11th. Encourage you to check it out if you didn't. This is a guy that enlists at 16 years of age. He's trained by World War I vets. He called them tough nuts. I love that. And he and his brother are soon on a ship. And the next thing you know, he's 19 years old, and he's there. He describes for us the morning of D-Day, saying goodbye to his brother because they expected that their ship was going to be blown out of the water, staring down Nazi artillery. I mean, just the Luftwaffe overhead. He's one of the gunners on one of these 20-millimeter guns. That his job is to shoot down the German planes so the thousands of young Canadian men that are storming Juno Beach can have the best possible shot. I mean, the stories that Marty shared with us were unbelievable, but in particular, he talked about life after World War II, including pursuing forgiveness and grace. Check this out.
Some of the enemy, the German immigrants, boy, they ended up good Canadians, blended in with us with no problems.
Marty, I don't know that everybody would be able to reach a point like that you did.
Yeah, but see, that's called forgiveness and grace. I never held a grudge. In 1979, when I was in Germany, one fella, I stopped there to stay at his hotel. He said, "Are you an American?" I said, "No, I'm Canadian." So he says, "You want to stay here tonight, eh?" I said, "Yes." And he said, "I own this hotel. I closed my restaurant, but I'll go open it up that you and your wife can stay here for no cost on me." And here he is, a former Gestapo. And I said, "Thank you." And boy, I was treated great in Germany by the enemy. We ended up good people, all of us.
That was just a remarkable. I was sort of pinching myself talking to him. This guy, 99 years of age. He's getting set to turn 100, and his perspective was amazing. I see the comment in the chat. Marty was an awesome guest. You say my only comment was that the show was too short. For sure. He had other obligations as part of his Remembrance Day that obviously limited our time with him, but just an incredible guy. Maybe it'll work out to get him back on the show sometime. He would certainly be welcome, to say the least. Ken wrote in after our shows on Friday and Monday. He said, I just finished watching back-to-back episodes of Real Talk. Thanks, Ken. Says, I totally appreciated both episodes dedicated to honoring Remembrance Day, but that episode where you interviewed Marty Jones about his D-Day experiences really touched my heart. Ken says, my dad also landed on Juno Beach on D-Day, and it was an experience that had an impact on him for the rest of his life. He says, we, his children, didn't really appreciate the immensity of that impact until much later in our own lives. And Ken goes on to share with us just a beautiful bit of writing he did, pages and pages. And Ken, we sure appreciate that. We also got an email from Mark who says, I really enjoyed the episode on Friday, November 8th. That included Lieutenant Colonel, retired and former member of Parliament, the Honorable Laurie Hahn. I know most people recognize Laurie Hahn for his 3 terms as a member of Parliament in Ottawa representing Edmonton Centre. I don't know that everybody knew that Laurie was a former fighter pilot for 30 years. He flew Starfighters and CF-18s. And when we asked Laurie Hahn what Remembrance Day meant to him, he knocked our socks off.
We talked about what it means to you, Remembrance Day. To me, it's 48 names. I lost 48 friends during the Cold War, flying airplanes.
48.
And my best friend going through pilot training, my son's godfather was killed. A young pilot on my squadron when I was commanding officer was killed, and that hurts when it's one of your own troops, so to speak. You know, Germany was especially hazardous. I think we were flying the Starfighter there and the F-18 later, but the Starfighter, we were always low level, always high speed, always terrible weather. A couple times I've had the stick buried in my lap, saying, geez, I hope this works. And
really,
I'm here because obviously it did. But for some guys, it just didn't. But you don't think of that at the time. When something happens, and it happened often, you say, well, yeah, you know, they're but for the grace of God. You know, could have been me. If you were... We talked about what it means to you, Remembrance Day. To me, it's 48 names.
So really just remarkable stuff, and you can
48.
You can find our
pilot training.
You can find this on our YouTube shorts. You can find it on our TikTok and on our Instagram. If you want to do it like you just did there, let it loop and loop and loop so we get the views. That would be fun. That would be great. But Laurie Hahn just doing an amazing job on our show, and it prompted Mark to write in. He said, my extended family on both sides has a long history of military service. It says both my mom's father and my dad's father served in World War II. Dad's father never came home. Mom's dad never wanted to talk about the war. They've always been heroes to me. It says a few years ago, I put together a roll of honor. This is amazing, Mark, with the names of family members who fought and served in combat roles over the years. Said also a number of cousins, other family members. But I keep the list to those most directly related to me, and I honor them every Remembrance Day. Mark says, they shall grow not old, as we that are left grow old. Age shall not weary them, nor the years condemn. All the going down of the sun, and in the morning we will remember them. Mark, that's beautiful. And he sends us the list of these names. I read through it, Mark. I don't know these folks, obviously, but that's sure meaningful, and tried to reflect on each of them. And Johnny, I wanted to do a fact check here from Donald. I appreciate this. I was talking to Laurie Hahn on the roundtable, and I said, Laurie, how many former pilots have served as members of Parliament? I said, you got to be in rarefied air there. And then I went, oh, there was Marc Garneau, right? The former astronaut, obviously, Liberal minister. He's been on the show before, former Liberal minister. And this from Donald, who's keeping us on our toes. He says, Jespo, I enjoyed your Friday talk on Remembrance Day, but a point of correction. It says, during your chat with Laurie Hahn, you mentioned that Marc Garneau was a pilot. He was not. He was a combat systems engineer in the Canadian Navy, which, by the way, lost the word Royal from 1968 to 2012. A CSE, a combat systems engineer, leads the sailors who maintain the ship's radars, guns, and other sensors on the ship. Calling Mark a pilot is a common mistake made by Canadians of all stripes. Regardless, keep up the good work. That from Donald. We love when people keep us on our toes. Talk at RyanJesperson.com is where you can do it. So we talked about the presidential election, the American election, and we welcome your feedback, your emails. And we got this one from Keith in Leduc. And Keith says, I never thought I would email into this show, but your election episode, the post-election episode on the 6th of November, Wednesday, really aggravated me. He says, perhaps you and Johnny both have a bias toward the Democrats, but why is this election result so surprising to you? He says maybe Johnny's like a blue no matter who guy, or maybe you guys weren't paying attention that close to the lead up of the election, but this was a simple matter of, are you better off now or before? Nobody asked for Kamala. She got thrown into this race because Biden lost his mental acuity. She didn't win a primary. And I agree, she did well in the debate, but outside of that, she didn't state her policy. She bombed several interviews. She didn't portray herself as intelligent, says Keith. She ran to be a presidential candidate in 2020 and stunk out the joint. He says, I agree, Trump is not a great guy nor a good role model, but this election wasn't based on who's the nicest or the most moral. It wasn't based on who you'd want to be the better aunt or uncle. People compared a 4-year term of Trump to a 4-year term of Biden-Harris and said, we want Trump. You know, Harris was attached to the border crisis, high grocery prices, 2 new wars, high inflation, and other hot-button topics. Keith and Leduc says, I would have voted Biden in 2020, but I would have voted Trump in 2024 because of the facts at hand. And he says, and remember, we already had 4 years of Trump. We survived. Times were fine. He wasn't a dictator. Take a deep breath. And he says, when Johnny said we weren't crying, I promise you it definitely came off as such. That from Keith from Leduc. So interesting. I know some people are talking about, though, how they're expecting this Trump presidency to be a little bit different. You know, like saying that he could be this could be one of the most powerful presidents, if not the most powerful president in U.S. history. So kind of an interesting one, but Keith from Leduc will take your point. And you can send us an email anytime to talk@ryanjesperson.com. We'll continue to get to those. There were more submissions that we received based on that presidential election that didn't make it into the flamethrower period, just because of time, just because of limitations. So keep those emails coming. And of course, every Friday, courtesy of our friends at the DQs of Northwest Edmonton and Sherwood Park, we've got you covered. Your hottest takes to talk@ryanjesperson.com, presented right here, the final episode of every week. That's the flamethrower. So as we wrap, we want to thank you for sharing your mornings with us, whether it's live on YouTube or the Mixlr audio app, or whether you're catching the show later. We appreciate you. We appreciate your investment into the subjects we're talking about. We appreciate your feedback. We appreciate you holding our feet to the fire and fact-checking us when necessary. And of course, if there's a guest or a subject you'd like to see us touch on, I saw an email that arrived just as we were doing this show about Financial Literacy Month. That might be a cool Real Talk Roundtable. Let us know. This is your show. Without you, there's no point for us to do this. We appreciate you, Real Talkers, and we'll talk to you again tomorrow.
Real Talk is hosted by Ryan Jesperson, executive producer Josh Dunford, technical producer John Hicks, general manager Katie Cook-Chivers, account coordinator Lawrence Derlego, human resources Lena Shepard, website design Mike Johnston, voiceover by me, Carrie Skelton. Real Talk's editorial board is Supriya Dwivedi, Ahmed Ali, Brandy Morin,